por sumarse al webinar de ejercicio de cardiopatías congénitas. Contamos en esta etapa con el doctor Guido Pieles, que es un cardiólogo especialista en cardiología pediátrica y adulto relacionado con cardiología del ejercicio. El doctor Guido Pieles es también tiene experiencia en lo que es, además de cardiopatías congénitas, cardiopatías hereditarias, es asesor del club Manchester United y también colabora con el Instituto Aspetar, Instituto Aspire de Qatar. En este momento, él está encargado de la sección de cardiopatías congénitas y ejercicio del Bristol Heart Institute de la ciudad de Bristol, del Reino Unido. Okay, Guido, you can share your screen and you can start whenever you want. Thank you very much for joining and for sharing your knowledge. Thank you, Guido.
So, thank you very much, Esteban, for the invitation. Thank you, everyone, for coming online. And maybe this is one of the very few good things of Corona, that we do more seminars online, which is enjoyable, although I would have loved to come to Argentina one day. So we will talk about exercise and congenital heart disease, and also a bit about sports cardiology and congenital heart disease. And I would like to give you some background, and then also introduce two cases to show you how we assess athletes with congenital heart disease, if they can compete or not. And I will show you some very new paper that is coming out in the European Heart Journal. It is in press. That is called the Recommendations for Athletes with Congenital Heart Disease. So this is a paper we have written with European colleagues to say, how do I have to assess an athlete with congenital heart disease? So Esteban has already said, I work in an institute in London, but also I work, which I still think is a better Manchester football team, although not everyone will agree. So I work for Manchester United, and then also we have research partnerships with Canon and with other companies in sports cardiology. So let's first talk about why exercise. Why do we spend so much time on exercise assessment in children and adults with congenital heart disease? This is a statistics from England, and this is quite worrying, and this is normal children. You can see the British Heart Foundation, a very good charity, looked at this and said, how many boys and girls do enough exercise as is recommended by the World Health Organizations? And here you can see the years, and you can see if you've got 15-year-olds, only 30% of boys do enough exercise, and this is even more worrying, only 15% of girls do enough exercise. Why is it worrying? Well, it costs a lot of lives. It costs a lot of healthy lived life, and it also, of course, costs a lot of money to the state and to governments. So it's very important that we do something to help children reach these goals and have fun during exercise. Now, why congenital heart disease? Congenital heart disease is something that previously was not so common. Not many cardiologists saw this. But if you look at this number, 1 in 150 young people have congenital heart disease in England and in Germany and Europe. So this is quite a lot. So even if you are a general cardiologist, when these children grow up, you will see them. So this is a lot. If you want to have a good job in Europe, then becoming a congenital cardiologist is something, because we need more congenital cardiologists. In fact, 25% more or even more. So the question is then, why, or do children and adults with congenital heart disease do enough exercise? Well, what we know from papers is that the activity levels and the exercise capacity, the fitness is lower in children and adults with congenital heart disease. Of course, you might say, of course, this is clear. They had heart operations. Of course, their fitness is lower, but the reasons are very interesting. Firstly, many people say to children and adults with congenital heart disease, please do not exercise. But this is wrong, and this is one of the first messages. This is wrong. It is safe. You need to know how to or what they can do, but it is good for them to exercise. Otherwise, they get all the problems, obesity, atherosclerosis. So it's very important. Very, very big point is what the English people call overprotection, which means, as I just said, parents, school teachers, but also doctors, we tell these children, please don't exercise. You had heart surgery. Please don't exercise. But this is also wrong, because these children need to grow up also having confidence that they can kick a ball, that they can run around with their friends and jump and swim. So big reason is really overprotection. Us as medical professionals, we say don't exercise. In England, only 10% of adults with congenital heart disease have actually rehabilitation training, and they need it most. So this is just a slide to show there's lots and lots to do. But many doctors ask, well, I would like to recommend exercise, but I'm not sure. Isn't it dangerous? I'm not sure. What can I do? What type of exercise? And I want to talk about it a little bit. How can we risk stratify these children and adults with congenital heart disease? Before I do this, I want to give you an argument if anyone says they should not do exercise. This is a very good paper. Of course, I can send you the presentation. The group of Michael Gatsoulis at the Brompton has published a lot of extremely good papers. So if you want to read on exercise, read Michael Gatsoulis, Gerhard Paul Diller, Dimopoulos. These are the good papers. And what this is a very simple diagram which shows here is the percentage of predicted oxygen consumption, fitness level from low to high, heart rate reserve by how much you can increase your heart rate during exercise. And this is how the breathing, the VCO2 slope. So when you breathe, how much carbon dioxide you can breathe off. So this is good here, this is bad. And you can see, if you're better here, if you've got a higher fitness level, your 5-year survival, if you've got congenital heart disease, goes up quite dramatically. The same, your heart rate reserve goes up. In fact, we know now that exercise capacity, fitness level in congenital heart disease is the most important outcome predictor. It is more important than who did the surgery and how well they did it within limits. And this is evidenced by this sentence, this citation. And I like it very much because it does not come from a sports cardiologist. It comes from a surgeon who normally cares about the operating theater and not about rehabilitation. But Yves Udykem from Melbourne said, the only advice he gives his patients after they had a good surgery is exercise, exercise, exercise. So this is another take-home message. Exercise fitness level is the most important outcome parameter for congenital heart disease. If you want to have values for exercise, for example, for oxygen consumption, fitness level in these patients, then again, this is a very good paper. And you can see these are the different types of congenital heart disease, from simple and atrial septal defect, ventricular septal defect, more complicated fontan circulation, and here Eisenmenger with pulmonary hypertension, really, really unwell patients. But you can see, and these are just activities we all do, swimming, bicycling, snow shoveling, all this. And you can see that for some with congenital heart disease, even walking, stair climbing, they already go, and this is your oxygen consumption here, they already have to almost go to their maximal oxygen consumption to do this. So if you, for example, have Epstein's anomaly, and if you want to just do some farming or go fishing, then you're already going onto your maximal oxygen consumption sometimes. So it's a huge effort for these patients to do. And sometimes we forget this. All things we can do easily, many of them can't do. So this is just a quick slide. So what are the problems? What are the problems during exercise with patients with congenital heart disease? And I'm not talking here about individual diagnosis, Fallow's transposition of the great arteries, just in general. One is chronotropic incompetence. If you test children and adults with congenital heart disease, and I mean here more complex ones, starting with tetralogy of Fallow, Fontan as well, transposition, even operated if chronotropic incompetence means they can't increase their heart rate. I test them a lot and I see when they're at a heart rate of 130, boom, that's it. They can't go higher. And this is one thing. The other thing is, we call it the force frequency relationship. Normally, if your heart rate goes up, your contractility goes up of the heart. This is normal in everyone, not only athletes. In children, adults with congenital heart disease, does not work for them. Then the stroke volume does not go up very much. So they've got only the heart rate to push their cardiac output. Then the anaerobic threshold is very low. So a lot of these children and young people, they work anaerobically a lot of time. And if you do some sports, you know it hurts because you build up lactic acid. This is not good. And their breathing is affected as well. And very importantly is they have got skeletal muscle weakness, even if their heart works. And not because of they're not training enough. They seem to have skeletal muscle weakness. This is very important as well. And a lot of training programs we do here in respiratory muscle training and skeletal muscle training. So let's say now, you know all this background, and now you have an athlete. It might not be a top athlete, what we call a recreational athlete, someone who wants to do athletics, wants to run, wants to swim, wants to do a triathlon, play tennis, play football, try to beat Germany in football. You know, you need to assess what they can do and how they can do it. So these are some very nice recommendations, but these came out in 2005, and I think they are very good. They were a first step to assess athletes with congenital heart disease. But it was very difficult, or became more and more difficult to use them because there's one problem. They classified a lot of the recommendations on the diagnosis. So they said, if you have tetralogy of Fallot, you can do this. If you've got transposition of great arteries, you can do this. But if you work with patients with congenital heart disease, you find out that everyone with tetralogy of Fallot is very different. Everyone with congenital, with transposition of the great arteries is very different. You cannot put two people with tetralogy of Fallot into one pot. So this is a problem. The next problem is how to assess the intensity of sports. You've seen this 100 times. This is a Mitchell classification of sports, and it is not good. It gives you a rough idea, but the English, rightly so, are very, very offended that cricket is here with a low static component, and here this is the dynamic aerobic component, and cricket is here. And I can tell you this is wrong. I'm looking after elite cricketers, England national cricketers. They are fitter than football players. It's incredible. So this classification does not really work. So you cannot, and also it is different. Someone might play basketball and they might be here because they don't push themselves very hard. Someone might be here, someone playing basketball might be up here. Not very helpful. The other classification is the exercise zones. And this is something that we use as well. So we do an exercise test, and then you look where the 100% heart rate is, and then you give recommendations on the percentage of the heart rate. And this is very easy. Now everyone's got a Fitbit or a smart watch to do this. But it is very difficult if you want to write a paper and you want to give general recommendations using these, either these exercise zones or what I showed before, the Mitchell classification, because there's so much variability. So the European Society, we thought about a lot how we could do it better. And this is a paper by, this was first used in a paper by Antonio Pelliccia, where we looked and tried to classify these sports in skill, power, mixed, and endurance, but then looked at the cardiac parameters that are infected, because that is important when I recommend exercise. I need to know what happens to the blood pressure, what happens to the cardiac output. We tried to put these sports down here. Many of you will not agree with this, and it is very difficult. I used to be a high-performance dinghy sailor with a trapeze, and I tell you, this is very, very, very tiring. So put it here to skills is not quite right. And I think it is a better classification than what we had before, because it looks only what happens to the heart and to the vascular system when you do it, but also in the long term in terms of remodeling. So we use this to give new recommendations. Last thing you need to know before you give recommendations, before you assess athlete, is what are the risk factors? So this might sound strange, but 75% of patients with congenital heart disease die of heart disease. Yeah, of us, we don't die of heart disease. There are so many other diseases, but most of them really, the limiting factor is the heart disease. Sudden cardiac death and heart failure are the main reasons for mortality. But if you look at this, only 8% of these deaths appears during exercise. That's not very much. People always thought, oh God, if you exercise, you die if you've got congenital heart disease. That's not true. What are the risk factors? This is just a general classification. Of course, if you've got very complex disease or if your heart is not working well, ventricular dysfunction, arrhythmias, of course, pulmonary hypertension, we know this, degree of cyanosis, or if you've got aortic disease with rupture, or indeed lack of physical training. So one has to have this in mind. So now we've got all the tools to assess athletes, and I want to give you 2 examples and go through how I assess athletes. And I will give you 2 real examples. I have 2 17-year-old patients with tetralogy of Fallot. And I thought, okay, I look at the 2005 guidelines. What does it say? So it says, if you've got tetralogy of Fallot, you've got normal ejection fraction, you've got no arrhythmias, you've got no outflow tract obstruction, you can read it yourself. Basically, if you're really, really, really well, then you can do exercise. If you've got ventricular dysfunction less than 40%, severe outflow tract obstruction, or you've got arrhythmias that you can't do exercise. My problem is with this, most of my patients, 95 patients, they are here between those 2. I've got rarely patients that fit into this category. There's no one. They all have a bit of dysfunction. They all have some ectopics, maybe even arrhythmias. So it's okay if someone is really well or someone unwell, then you know what to do. But if they're here in the middle, which are most patients, you don't. So I will show you these patients actually later, but what this just shows is they've got the same diagnosis. Look, here you can see there's right ventricular dysfunction. Here you can see the right ventricle is working really well. They are the same age, they have the same diagnosis and look very similar. 2 patients with Fallots. Why are they different? And with this in mind, Werner Butz and Michael Papadakis, who you've heard before, have come up with a paper in 2013, which is a very good paper to look at individual exercise prescriptions, where you look at certain parameters, and then you assess if they can do sports. What we've done now this year, we took this paper, we took more of our friends and colleagues and excellent sports cardiologists into the group, and we've rewritten this. And we've written this to make it recommendations for participation in sport with athletes with congenital heart disease. So this is the press for the European Heart Journal. It's very soon, and you can see there are excellent pediatric and adult doctors there. And this is also the first paper in sports cardiology from the European Society that was written with the ESC, with the sports cardiology group, but also with the pediatric society. So that's excellent. So we are quite proud of it. So how do we do it? How do we assess these athletes? Well, we have 5 steps, and we try to do this like how we would think in a clinical environment when I see a patient. Of course, the most important step is history and physical examination. Of course, we do it all, and it is very important for congenital heart disease. Once we've done this, we assess 5 parameters at rest, and I will tell you what these 5 parameters are, and then we will go through 2 examples how to do it. So these parameters at rest need to be assessed. And of course, we need to assess what happens during exercise to the heart. And then only when we take all these 3 steps together, we can recommend then the type and the intensity of exercise. And then the 5th step is, which is for me the most important one, we cannot only see them once. They need to be followed up longitudinally. And we recommend, even if they're proper athletes, once a year, sometimes even every 6 months. So let's have 2 patients, and these are real patients of mine. Nothing is imagined. I haven't prepared this for the talk. There's one boy called Fraser. He's a footballer. He does play for school and at one of the higher national leagues, so 16 years old. He's very good. And then it's Chris. He's a tennis player. He got a scholarship for the University of Chicago to play at the pro circuit, which is, as you know, which is a last circuit before you become a real professional in the ATP tour. So both have tetralogy of Fallot. Both are 16 years old. Both had operations in childhood. They were operated. They did not have a BT shunt. They were operated straight away within the first 6 months, had a correction of tetralogy of Fallot where the BSD was closed, the right ventricular outflow tract was opened up. They had a reoperation when they were 13 because their outflow tract in the right ventricle was too small. So our typical fallow case. So we examine them. We said the first step is physical examination. They have no dizziness, they have no palpitations, no syncope. There's no family history. So then I asked him about how did you get on when you play football. And he's an athlete. He knows his fitness. He says, I'm very good. I still score goals, but sometimes since half a year, I get tired at the end of the game. Whereas Chris, the tennis player, said, I can play a 5-set match, no problem for me at all. There we have a little bit of a difference as well. Both of them came to me because their clubs and in fact the National Association wanted to have my recommendation, can they play or not? So it's very important as well to do an honest assessment. Of course, both of them want to do their sports. It's everything for them. So examination, typical fallows, and both were the same. They looked athletic. They had a systolic heart murmur from the right ventricular outflow tract, but the pulses were good. So we've done our assessment here, and I didn't find anything apart from maybe reduced exercise tolerance, what he told me. So now look at these 5 parameters. What do we assess? And this is not only clinical examination. This is a bit busy, but you can read it up in a paper. First thing we assess is the ventricles. What is the ventricular function? And it doesn't matter if they've got transposition of the great arteries, fallows, Epstein's. This is a diagnosis independent, individual protocol. And this is a good thing about it. So you've got either no dysfunction or you've got severe dysfunction. And then you go down, and if you've got all green, then you can do all sports, or you can do only skill, power, or mixed sports, like in the diagram I showed you. And here you can do no competitive sport. You assess the ventricles. Very important, you assess the right ventricular or pulmonary pressures. You look where they are. You assess the aorta if there's dilatation, because that is a risk factor for sudden cardiac death during exercise. You've got 4 categories. Then very important, arrhythmias at rest during exercise. Saturations at rest during exercise. And all these you take together. And for example, here, if you've got more than one parameter that is here, so if everything is green, but I have maybe arrhythmia, then they cannot do endurance sport usually. You might say, well, this is not very clever. This is normal. And if you say that this is not very clever, I would be very pleased, because it's not meant to be clever. It is meant to be what we do, you do every day when you see patients. We just wanted to give it a uniform way to help to assess these patients. So we do all these things. So then I examined these 2 boys and said, okay, let's look at the arrhythmias. So these are the 2 ECG of these boys. And here you can see, oh, it looks a bit different. If you work with fallows, you can see this is a typical fallow. There's right bundle branch block. You know, the QRS complex is probably here, 140. It's above 120. So this is a risk for arrhythmias. This here, the right ventricle looks much better. There's no white QRS complex. You also haven't got these repolarizations, which I have to say I don't really like, but often this can be due to surgery. So I would not say this is either ischemic or cardiomyopathic, not at all. So the ECGs are maybe a bit different. Then we did a 24-hour Holter, and you can see they've got typically monomorphic ventricular ectopies coming from the right ventricular outflow tract. Both have it. He's got it a bit more. But there were no sustained arrhythmias. That's important. But he had more ectopics. So while I tolerate this, I would say, this is not 100%. So we've done our arrhythmia. Now we look at our ventricular function. This is a footballer, and everyone who does echo will see 2 interesting things. Sorry, I've got the strain image here because I want to talk the strain in a minute. Left ventricular function is okay, but you can see the septum is mildly dyskinetic. You can also see the left ventricular is, the right ventricle is dilated, and maybe it's not working well, but for a fallows, that's what we see all the time. And it's interesting that he was playing very, very high level football with us. You can also see here the septum is flat, so the right ventricular pressure is probably high, whereas in our tennis player, this is actually much nicer. So ventricular function, I would say as well, that is a bit worse, but I haven't got any numbers here yet. Then our algorithm says, have a look at the pulmonary pressures. Have a look at the right ventricular pressure. So this is at rest. This is the TR velocity. So 4.3 meters. So here it is 3 meters. So this is maybe a RV pressure of 35 to 40, and this of 35 to 80. So in our footballer, it's higher. And at this stage, I say, this is almost a bit too high for me. And I thought, Can I really let him play or not? But I knew I still had to assess him during exercise. So remember, we have the ventricles. So we say in our footballer, maybe there's mild systolic dysfunction. There's clearly volume loading. But in our tennis players, volume loading as well. But dysfunction is not as bad. Pulmonary artery pressure is clearly higher in our footballer and in our tennis player. The aorta, I will not show you. They were normal, although sometimes in fellows it can be dilated. Arrhythmias at rest. Well, there were more ectopics in the footballer, so he would probably be here. And saturations at rest and exercise, we will have a look at. So we need to look at the saturations at rest and exercise, and we need to look at exercise in these two boys. So the other thing of ventricular function, of course, is an MRI scan. So I would not only rely on echo. And you can see in our footballer, the ejection fraction is a little bit low in the left ventricle, and it's surely low on the right ventricle, whereas in our tennis player, it's normal. And the volumes you can hear as well. End-diastolic volume is very important in tetralogy follows. Again, this is higher than here. So I keep all these in mind, but I would like to assess him during exercise. So we've done this. We've done our 5 basement parameters. Now I go to the exercise test. So we did an exercise test. This is a footballer. I'm sorry it's a bit small, but I will only tell you the important numbers. So his oxygen consumption is 40 mils per kilogram per minute. This is quite good. I'm not sure how many of you have an oxygen consumption of 40. I think this is quite good. Premier League football players have between 55, 65, long Tour de France cyclists, 75, 80. So 40 is very good. He's got chronotropic incompetence, as I told you. His maximal heart rate was 156. That should be higher. So there are some things that are not quite normal. And his oxygen pulse, which is an indirect measurement of cardiac output, 16 of 12. So this is good. So his heart is, on this data, functioning not too bad. Our tennis player even topped this, 47. The anaerobic threshold is also very important, which was here 56 in our footballer, and here 61. That is not bad. But the heart rate and the oxygen consumption in our tennis player are better. However, if you put this together into the general fellows data, so this is a mean VO2 of fellows for young adults. 25 is the mean. Our boys are here. And this is another message. Sometimes if you're an athlete, you will of course be fitter, but don't be fooled. They might still have cardiac problems, but they might have high numbers because they are fit. So we would say the fitness masks actually maybe some dysfunction. And remember, our footballer had dysfunction at rest. So what we do in our center is we do exercise stress echocardiography, which we also quantify with strain. So this is something what we do in our center, and I also do it a lot with athletes. So we use strain measurements, and we do VO2 at the same time on a reclining bike. So we get also exercise stress echo. So we get cardiac function, we get fitness level, and we often do an exercise stress ECG. So we do a test, takes 50 minutes, and we get a lot of information. So this is quite something new, but it works very well to assess it during exercise. So what happens during exercise? Look at our footballer. His right ventricular pressure, which was 75, goes up to 112 at 100 watts exercise. We go up in 25 watts stages of exercise. And our tennis player goes up as well, but not as high. But this is clearly high. This is not quite suprasystemic, but it's very high right ventricular pressure. And remember, this boy said he does not feel he's super fit like he used to be. So what I wanted to say is, what happens with this pressure to his right and left ventricle? And the beauty is, if we do exercise imaging, we get this data. And if you look here, for example, this is now at 100 watts in our footballer. And you can see the left ventricle is working, but the right ventricle is very, very dilated. It is just like a sailing boat in waves bobbing too, but it's not fully contracting. Look at this, both fellows tetralogy. This is a nice contraction of the right ventricle. It's less dilated. But this ventricle cannot cope during exercise. Of course, you might not believe me, so we quantified this. So we did strain imaging and this is during exercise, not at rest. It's at 100 watts exercise. His strain of the right ventricular was 19 at rest. 1920 is normal. Strain should go up, so more minus during exercise, but look at this. Firstly, the strain is going down, and secondly, you've got the synchrony. So these yellow-green is the lateral wall of the right ventricle. So you can see the right ventricle is actually not moving during exercise. Whereas in our tennis player at 100 watts. This is almost a normal right ventricle. So clearly, although his parameters at rest might just be okay, during exercise, this footballer, this right ventricle is not coping. It's not coping at all, and I think this is also why he has problems. Of course, if you're interested in echo, of course, what happens to the left ventricle? You can see the septum flattens even more during exercise because the right ventricular pressure gets higher. Now, a footballer, a flat septum, a dysynchronous ventricle, whereas here, it's almost normal during exercise in our tennis player. So then the question is, I had to tell this footballer, I said, I'm not very happy with you competing and training so much. Your right ventricle is already borderline and not working during exercise. And I sent the tennis player home with a big smile because he can compete. However, he came back and said, I want to compete. I want to play football. It's my world. And then we sat together with him and with our surgeons and said, because his problem was clearly the right ventricular outflow tract, the pulmonary valve. So we decided not to operate, but to put a melody valve in via catheter, because this is obviously much less invasive. And then we've got here his pictures. This is right ventricle after he had, and remember, this was very dysynchronous. So he had a melody valve implantation. This is 4 months afterwards. And you can see the right ventricle is much more synchronous. It's much more contracting, much better. And also the left ventricle is contracting beautifully normally. And if you've got the short axis function of the left ventricle, remember his septum was flat before? You just put a new valve and the pressures are low and it's much better. Of course, we imaged him during exercise as well. And this is the left ventricle during exercise. Beautiful synchrony. Again, beautiful synchrony. And then we imaged the right ventricle during exercise. And I will show you this as well in a second here. This was before we put the valve in. You can see very, very dysynchronous, not moving this right ventricle. I'm not saying this right ventricle is normal, but it's moving much better and it's much less synchrony. So these curves before and here, they are better. So then he started playing. We did all this effort. And I tell you what, of course, he played for another year, but guess what happened then? Girls. He met a girlfriend. He stopped playing football. But he was very happy that he was still very fit and very grateful for us to put a valve in. So what I want to do with this is just illustrate that this stepwise approach in congenital heart disease, do a proper examination, assess the 5 parameters, which is ventricular function, pulmonary pressures, aorta, arrhythmias, and saturations at rest and exercise. Then do an exercise test and then follow this protocol and you will have a safe approach to making these athletes work. Why is this important? Well, you probably know this and everyone knows it now. Sean White, I mean, he's an Olympic champion in the half pipe, but also in the snowboard. He had exactly what my 2 boys had. He had now 2 operations, tetralogy of Fallot, and he became twice Olympic champion. So this is fantastic. And he's probably a very good example to give all our children hope that even though they have congenital heart disease, they can still exercise. And of course, our recommendations are for these athletes as well. But at the same time, they're also for him. This is one of our patients who've got corrected transposition of the great arteries. However, with unoperated, he had a buffle, but then the buffle leaks. So he's got cyanotic heart disease. You can see the blue lips. You might even be able to see the typical textbook clubbing. He's got a wheelchair here. He cannot even go the stairs up to the gym. He needs to use a wheelchair, but he does his weight training, which is very important. And this is also someone with congenital heart disease. So you've got this wide spectrum, and it's very important not to assess people by their diagnosis or by their operation, but by their individual capacity, which you can basically assess with approach I've showed you. So in summary, congenital heart disease is very common. Exercise is the most important outcome predictor. And what I haven't mentioned it, of course, quality of life. Makes them feel better if they can do exercise. And it doesn't mean skiing. It might only mean to go out and see their friends and walk for 2 kilometers without problems. These new recommendations, I think they can really assist in individual decision making. Because remember, same diagnosis, they might have a very different function and they might have a very different risk for sudden cardiac death, for arrhythmias. So individual assessment is key. And for me, exercise assessment is a core. And this was also one message I wanted to deliver with these cases. Although both boys had reasonably good function for tetralogy of Fallot at rest, even the football player. But during exercise, as I always call it, his right ventricle fell apart. But you need to assess them during exercise because that's when they have symptoms. So you need to assess them during exercise. The other thing, of course, one assessment is not enough. You need to see them because things change. They can have arrhythmias, they can have dilatation, they can have narrowing of their conduits, of their valves. So you need to see them regularly, probably once a year. That's what we do. And of course, this also, the work I showed, is not a one-man show. This is a group of people who are sports cardiologists, congenital cardiologists, and work together. So this is very important. But I think if we get better in this, and if you work hard, then we can really give these people a more fulfilling and really, really better life. Good. That's all I wanted to say for now. Thank you very much.
We will finish your presentation. Guido, again, thank you very much for your kindness. Really outstanding presentation, and hope you may share some papers with the audience in the future.
Of course. Thank you very much for the invitation, Esteban, and to everyone. Have a nice day in Argentina. It was a pleasure talking to you.
Yes, thank you very much. Bueno, muchas gracias a todos por haberse conectado. Damos por finalizado el webinar de ejercicio de cardiopatía congénita. Hasta luego. Bye bye, Guido. Bye bye.
Bye bye. Thank you.